what I want to do in 20 minutes or so, just tell you a little bit about personal health budgets, about the study and the results of the work that we undertook, and a little bit on some of the methods we used in the evaluation, hopefully to convince you that our results are sound. So the Personal Health Budgets programme, I think it's a key part of the personalisation agenda. Clearly we've had personal budgets around in social care for a while. This is a pretty radical step, I think, for the health service, and it's clearly a mechanism that has potential to really help people personalise their care services. The aim is to encourage the NHS to be more responsive, to offer greater choice and control, especially to people, allow them to tailor their care around their own particular needs and preferences, and move away from a kind of one-size-fits-all model that sometimes can happen otherwise. These ideas really came forward in Darcy's next stage review, and just after that the Department of Health invited PCTs and their council partners to bid for a pilot in the personal health budgets evaluation. So the underlying principles really is that you're given a budget rather than care directly, and you know the level of resources that are associated with that budget. People are encouraged to then develop a care plan, to formulate a way to spend that budget to meet their particular needs and address their desire to improve their outcomes. And of course, primarily to have choice over how that's achieved. Briefly, there were three broad deployment options that were used in the pilot phase. There was a notional budget, whereby the budget was still actually held by the NHS or partner organisation, and although the individual in theory knew about the budget themselves and was involved in the care planning, they didn't actually spend the budget. Another option was whereby the third party was there to manage the budget, to hold the budget on behalf of the individual as a third party or independent of NHS organisations, but still the individual worked with the third party rather than holding the budget themselves. Finally, there was the direct payment option, where the person actually received real money in a bank account to spend according to their care planning process. So often people ask, what can a personal health budget be used for at least during the pilot phase? And well, a lot of this idea and development happened as the pilot proceeded, but at the onset it was quite clear that what wasn't going to be covered were things like secondary care, emergency care services, even GP services, and generally stuff which was frowned upon or deemed unlawful, as the list goes there. But otherwise, the idea was that it should be pretty open, that people should be able to use their budget in a way that they feel meets their care needs and helps to improve their own outcomes. So there were a lot, for example, a lot of people were using their budgets to pay for personal care, for equipment, a lot of therapy services, nursing services, complementary therapies. Also kind of leisure or well-being or services like to improve their exercise and to facilitate those kind of lifestyle choices of individuals. So the evaluation took place over 3 years, from 2009 to 2012. Originally there were around 64 sites that were piloting personal health budgets, but of those 20 formed an in-depth evaluation, and the rest were a wider cohort. Our evaluation concentrated on that 20 site PCT council sites for the main evaluation. And our aim was to see how personal health budgets are best implemented, whether ultimately they worked in a sense, where and when they were most appropriate for which groups of people, for example, and what sort of support would be required to make personal health budgets work if they were to be rolled out more generally. those were the kind of exam questions that we were set at the onset. It was a multi-site research program, PSSRU at the University of Kent, Social Policy Research Unit at York, and you will hear from Caroline in a minute after me, and also colleagues from Department of Social Policy, LSE, and Imperial College. So we put together a pretty pragmatic design for this study, given the complexities involved and the difficulties of evaluating a sort of system intervention rather than, say, a drug or something which was more self-contained. So what we wanted to do was to put together a group of people who received personal health budgets and then contrast their experiences with those in a control group. And that control group and personal health budgets group was chosen either through a randomization process, or in other sites it was chosen on basically a site-by-site basis within the overall area of the evaluation. So where one group of health professionals were using PHBs, they would be compared with people drawn from practices where they were using conventional methods of service delivery. Now, we did a baseline and a follow-up. So we took people at the start of the process and we followed them up over a period of time. The main follow-up period was 12 months. And the aim at the onset, at least, was to have about 1,000 people in the main intervention group, the PHB group, and 1,000 in the control group. What we did was to focus the evaluation on these 6 groups of service users, patients, those receiving NHS continuing health care, diabetes, mental health, COPD, stroke, and neuro. And what we did was to try and collect as many markers as we could to try and measure what the impact of those services would be, to try and see what outcomes having a PHB had on people in a range of different indicators. Some of the ones that are commonly used are related to well-being or quality of life, health-related quality of life, for example, care-related quality of life, psychological well-being, subjective well-being. So those are kind of well-being or quality of life measures. And we also measured clinical outcomes, lung function, hemoglobin tests for diabetics, and mortality rates over the follow-up period. On the cost side, we collected as much as we could in terms of what people's service use was. So although primary and secondary care wasn't included in what people could spend their budget on, in case there was an impact on how much people use those services, we measured both primary and secondary care service use over the period. Social care service use, community health use as well, it's not on there. Therapy services, a whole range of things that people could potentially use. And also we had the care plans for all the 1,000 or so budget holders, and we went through those and analysed in detail what they'd use their budgets for. Just a quick word on missing data. It's a complex evaluation. There were missing data at various points in the analysis, and so we used statistical techniques to deal with some of that, and if people are interested, then I'm very happy to talk at length about it, but I'm sure that will be a minority of people. In the end, what we had was just under 1,200 people in the personal health budgets group and just over 1,000 in the control group who were in the full study, baseline and follow-up. So how do we evaluate the impact? Well, essentially what we want to know is what the experiences are of people using personal health budgets. But in doing so, it's also important to understand what the counterfactual was. What would have happened to them had they not had a personal health budget? Because that's ultimately what you want to compare to see whether individuals themselves, how their experiences changed through having personal health budgets. So as I said before, we used a controlled design. We had a group with personal health budgets and we compared those to people who were using conventional means of service delivery. Now, because of the complexities of these sorts of evaluations, it's still likely that the kind of people in the control group and the kind of people in the personal health budgets group at baseline aren't exactly similar. So we used a method called difference in difference to try and adjust or account for the potential that there were differences in the groups before they even had personal health budgets. So what you do essentially is at the follow-up period at 12 months, you compare the experiences of people in the PHP group with those in the control group, and you subtract from that difference any differences that existed at baseline. So the idea is that you remove any baseline bias or selection bias, as it's called. We also added a further control of standardizing on the usual suspects, so socio-demographics, age, sex, baseline dependency, and so on socio-economic factors where we could, education and benefits receipt, and on their health markers at baseline. There were a real range of personal health budgets put in place. They varied enormously in terms of the implementation models I talked about before, but also what exactly they could cover, the size of the budgets and so on. And what we needed to do was to try and boil them down into a sort of manageable number of actual personal health budget types that we could use in the evaluation. So we did that and came up with 5 models, and they varied according to essentially the degree to which people had flexibility in use of their budgets, the deployment options that they could use, whether it's a direct payment or third party, as I said before, how much flexibility was involved, and how informed they were in the process, how involved they were in the care planning process, how much they knew and understood about the budget themselves and what they could do with it. And also the size of the budget as well, because they varied enormously as well across the pilot sites. In some places, budgets were being offered really as sort of top-ups on what people usually got. And the amounts in the budgets were pretty modest in some cases, £500 a year in some examples, obviously a pretty small amount. Others were much more substantial and were clearly substituting for conventional services. So rather than getting conventional services like, for example, continuing healthcare, people were actually given the value of those services in the budget, and they could then go and use those. So they were much more substantial. So some results. The impact of personal health budgets on outcomes to start with. So was there any evidence of personal health budgets led to better outcomes compared to conventional service delivery? Was there any evidence that those specific implementation choices led to comparatively better outcomes than others? And what factors were associated with the degree of outcome change? They were the specific questions on this outcome part of the work. So what did we find? Well, overall, in terms of the whole sample, not distinguishing particular groups, we found in terms of well-being that personal health budgets had a significantly improving effect on people's well-being and quality of life. So on these 2 measures of care-related quality of life and psychological well-being, personal health budgets group, after doing the controls I talked about before, showed significant improvement compared to the control group, compared to those receiving conventional service delivery. On health, however, there didn't seem to be much of an impact over the 12-month period of the analysis. So we didn't find significant differences in mortality rates or in terms of health-related quality of life, and there was no real difference in their clinical markers, their clinical outcomes. So to sum up, what we found was actually personal health budgets seem to be improving people's well-being, but they weren't actually improving people's underlying health status, which is perhaps not that surprising given we were only talking about 12-month period for people with long-term conditions. It will be interesting to see what the longer-term impact will be. Now, because we had a fairly large sample, we had an opportunity to try and look at whether specific groups did any better or any worse. The problem with doing this is that as you start chunking up your sample, you lose sample size for those individual groups, and that reduces the statistical power of the analysis. Again, I would enjoy spending time explaining that in detail, but probably for some other time. Implementation models Well, what we found in terms of implementation models was there was definitely a stronger effect where people knew what their budgets were. I mean, it may sound slightly surprising, but in a number of cases, people weren't exactly sure what the size of their budget was. When they had good information, and also when they felt they had a degree of flexibility and choice about how their budgets were used, then that showed a better effect, a stronger effect overall. Also, in terms of budget size, for the large, high-value budgets, then we also found, again, that they showed stronger positive effects. That's perhaps not surprising, but it's a result which it's always good to see in terms of the confidence you have in the results. And health conditions. If you just look at the specific health conditions, it was only in the COPD group where the effects were strong enough to offset the small sample size and show a significant difference. So in other words, it was particularly strong for COPD patients. So just to turn to costs, as I said before, we collected a whole range of service use information and costed that up. We also looked at what was in the personal health budget care plans and costed that as well. What we found was that the indirect costs of inpatient care was significantly lower for personal health budget group. So personal health budgets seem to be having a knock-on effect on the amount of secondary care that some personal health budget users were having to draw on over the period of the study. On the other hand, the direct costs, the cost of services actually that could potentially be covered by the budget, were higher for the personal health budgets group. And so when you put these two things together, overall we found no significant difference in the cost. So generally speaking, the costs over the course of the year for the services people used, either procured through their budget or through conventional service delivery, were about the same. So that leads us to the question of cost effectiveness, where we bring both the costs and the benefits, the outcomes, together. So when we question cost effectiveness, we would like to know whether the benefits are greater and are the costs lower. We put those things together by taking the value of the benefits and subtracting from that any differences in costs. So what ideally you'd want to find is that the value of the improvement in the value of benefits you see from a personal health budget, when you take away any differences in the costs between the personal health budget and the control group, show that there is a net overall improvement for personal health budget holders. Now, we had a sample, and a sample, of course, tells us about the true effects of personal health budgets, but it is only a sample and so subject to normal statistical error. So the way to represent that is to resample the data and look at the numbers of cases in which we found personal health budgets to be cost effective. So this chart shows you care-related quality of life outcome measure against costs for the whole sample. And what it shows is essentially anything where the dots are in quadrant A, or at least to the left of the ray that's slanted on the diagram. I might have a pointer here. That shows that they're in a cost-effective range, i.e. they showed better improvements in outcomes and or lower costs. And so pretty convincing results in respect to care-related quality of life, showing personal health budgets to be cost-effective. Same thing, but this time for the health-related quality of life measure, EQ5D. In this case, the results are much less clear, more ambiguous, and in fact, overall, it's difficult to conclude that there was an effect, as I mentioned earlier on. So, to sum up, cost-effective in relation to care-related quality of life, not more cost-effective in relation to health-related quality of life. And subgroup effects, in this case, again, caution about the sample sizes for the subgroups. We found there were particularly strong effects for people with mental health and the mental health subgroup, for those in the continuing healthcare group, for people with budgets which were implemented again with a high degree of choice and flexibility, and also to mirror the results on outcomes where those were high-value budgets of at least £1,000 or more over the year. So we didn't find strong enough effects to be confident there were real differences for other subgroups, but again, that may have been just the fact that we have a smaller number in those groups. So last slide, recommendations for policy and practice that come out of our evaluation. Well, in general, what we found is that personal health budgets were cost-effective on the well-being and no less cost-effective in terms of health. High-value personal health budgets were the most cost-effective, so when there was a real commitment to actually substitute for conventional service delivery with personal health budgets, that seemed to work. So there's a message about being brave there. And personal health budgets were more cost-effective for certain groups overall in the evaluation, particularly those with mental health problems and those who were receiving NHS continuing care services. So those were the recommendations we fed in, and Department of Health taken that forward and have announced a rollout of personal health budgets initially for NHS continuing care, and we wait to see whether they decide to roll out further. Thank you.
Thank you very much, Julian. Do we have any questions? Oh, I've sort of plunged into darkness there. Sorry about that, I was distracted. I think there's a gentleman there. Hand up.
Hi, two questions. One of them was, how many of those people were also receiving social care direct payments, and was there any read across between the two?
Yeah.
And the second one was, in terms of the quality of the care planning that led to the services being defined, was there any correlation? Is there any effect related to the quality of that work?
Okay. I can't tell the exact proportion off the top of my head, but there was a high proportion of people who were social care personal budget holders. In many cases, they were pooling the personal care budget from social care and the personal health budget. And so, yeah, that was certainly a key factor in how the pilots were set up. The second point on care planning, the quality of care planning, we only concentrated on the degree to which the person was really involved in that care planning process. So although we had the care plans themselves and we could go through them, we didn't try and classify in any extent on terms of, the sort of detail of the content. That's something we could potentially do, and we are actually now bidding for funding to do some more detailed analysis on that subject. But I would certainly say that the nature, the type of the personal health budget did have a pretty big impact overall. So it shows, and it's perhaps not surprising that that one kind of personal health budget is not going to work for all people. They themselves need to be tailored in the same way that people use those personal health budgets to tailor their own service use. So I think a strong message for implementation is to make sure this is not just a one-size-fits-all policy, and that there are degrees that people can use in terms of shaping their personal health budgets.
I actually have a follow-on myself from that. Did you do any work on changes in the type of services accessed? For example, some people with long-term conditions, they go in peaks and troughs. Yeah. Traditionally, when things are very bad, that's when you get services. But actually, if you could get them in the bit in between, you might be stronger for the next trough as such. Yeah.
I think, clearly there are issues about generalising too far, but I think a strong pattern that emerged from the study was that people were moving much more into the kind of well-being service end. So they were moving away from the conventional services, and they were tending to buy more well-being kind of support, social care, personal care things, and that showed quite significantly throughout the study. There were people also that were clearly going outside of conventional service delivery patterns, buying from outside of the NHS, securing services from non-care or at least non-conventional care providers. And so we did see some innovation in that respect in the study, yeah.
Other questions? I'm sure there's got to be a few. Well, let's go to that one and then that one, please. Yeah.
When they did personal budgets in social care, a lot of the authorities found that people didn't actually spend all the allocation that they'd been given. Did you find that people actually spent up to the full allocation, or was there money left at the end of the pilot?
It did vary. There were certainly cases where people held on to a small surplus. I think and this will be interesting because this was obviously under pilot conditions. So, the pilot sites were very supportive. They were keen, and they helped the budget holders to quite a high degree. And so I think there was quite a lot of pressure to make sure that people were using their budgets. It'd be interesting to see whether in a practical implementation, whether people would still use the full value of their budgets. In terms of the size of the budget, as I've said, it made a real difference. When they were relatively small and kind of just as add-ons, they weren't having a great deal of effect. But for people where it was, significantly a substitution for the conventional service that they might have otherwise received, then that had a big impact, and so was really changing their quality of life.
Now there was, lady there.
I'm really asking about something that's not been in your presentation, which is when the pilots were originally formed, one of the areas that they were intended to look at was end-of-life care.
Yeah.
Now, there is nothing really in the evaluation reports which addresses the appropriateness of personal health budgets for end-of-life care. So is that because, is there a reason for that? And do you have a view about whether there is an appropriate format of personal health budgets for end-of-life care?
I think I've just had a quick look towards Caroline. She's going to pick up on some of those issues, I think. So it'd probably be better if she answers that question. We didn't include it in the main quantitative analysis purely because there weren't enough people. And so, we wouldn't have been able to generalise in the way we were able to for the other groups. But the qualitative work did touch on end of life, and Caroline will talk about that.
And as the clock has ticked round to 1:30, and we're about to hear from Caroline, I think it's time to say thank you very much for Julian, who I also know was a last-minute step in on this. So thank you very much for that, Julian. We'll just give people a moment to come in and out.